Hi, I'm Dr. Naomi Parrella. I'm the Chief Medical Officer for Zero, the world's #1 fasting app. And today we are having a conversation with Dr. Sujit Janardhan. So I would like to read his bio because it is so extensive and he's such an impressive human being. I don't want to miss anything. So bear with me. Dr. Sujit Janardhan is an MD PhD. He's an associate professor of medicine in the section of hepatology at Rush University Medical Center in Chicago. He's the medical director of liver transplantation, the director of the weight intervention in liver disease clinical program, and a co-founder of the Rush Metabolic Health Consortium. He obtained his MD and PhD at the University of Chicago, where he also completed his residency in internal medicine and a fellowship in gastroenterology and hepatology and advanced research. He's board certified in internal medicine, gastroenterology, and obesity medicine. His clinical focus is the care of patients with chronic liver disease with a specialization in treatment of metabolic dysfunction-associated steatotic liver disease, otherwise known as MASLD. His research interests include the development and optimization of care pathways designed to treat obesity and metabolic syndrome in patients with liver disease, as well as the use of computing technology to facilitate chronic liver disease management. He's a principal investigator on several national clinical trials for patients with liver disease and serves as an industry consultant, speaker, and key opinion leader for his expertise in chronic liver disease. You can see he's a very impressive individual. And after a conversation with Dr. Lustig, where we talked about the 3 kinds of fat, one of them being liver fat, we knew we had to talk to a hepatologist, which is another way of saying a liver specialist. And who better than Dr. Janardhan? So please enjoy my conversation with him because he is just a wealth of knowledge, and his expertise is something that we're all trying to learn from. So here it goes. Awesome. All right. Well, thank you for joining us, Dr. Janardhan. We are so excited to have you.
It is a pleasure to be here, and anything that you're a part of, I'm proud to be a part of.
Oh my gosh, you are so wonderful. Okay. So the first question we have, I think we talked about before that after talking with Dr. Lustig and his explanation about liver fat, we became intensely curious about learning more. And of course, I don't know anyone who's more of an expert in this space than you are. So I just thought we have to talk to Dr. Janardhan. So could you tell us a little bit about fatty liver?
Yeah, absolutely. This is something that I'm extremely passionate about. When I was a trainee, my boss was a hepatitis C expert, and there was this thing, fatty liver, that everyone was talking about that was getting to be more and more of an issue. And she's like, I don't want to do anything with that. And I'm like, that's all you deal with that, and I will just do my hepatitis C things. And of course, she's now coming around. She's going to be the future president of the National Liver Society, and so she has come to love fatty liver disease too. But from that early spot in my training, it became something I was passionate about. Just not just because it's a liver disease, it's just another liver disease, but because it has so much intersection, right? It has such an intersection in metabolic syndrome and obesity. And then when you take the parallels from that, it has so much about not just population health, but mental health. And it really just kind of runs the gamut of the care process, from genetics to, family dynamics to socioeconomic impacts, et cetera. So it really is the epidemic of the modern times. We think of diabetes as being extremely common, but NAFLD, which is the formal name, now called MASLD, which is the formal name for what we used to call non-alcoholic fatty liver disease, affects 35% of the population. That makes it 3 times more common than diabetes. And a third of those patients have a more dangerous version of MASLD called MASH. And we'll get into the details later. But that's the type of liver fat that can lead to cirrhosis and liver failure. So we're talking about a third of that 35%. So that's roughly the same number of people that have diabetes in this country have this highly dangerous fatty liver disease. And so, when we're talking about fatty liver disease, it really is important to understand what that name means. The traditional name was non-alcoholic fatty liver disease, which I think you and I, both as obesity medicine specialists, can agree that that is just an absolute terrible name for a metabolic disease. Because, first of all, it's non-alcoholic fatty liver disease. So it's non-alcoholic, but what is it, right? It tells you nothing about what the disease is driven by, what the disease is caused by. So when I tell people that their diabetes led to their cirrhosis and liver failure, they're shocked. They're like, what is this? I've never heard of this disease. I don't drink alcohol. I don't have hepatitis C. How could I have cirrhosis? So it accurately places this disease dead center in the middle of the metabolic syndrome, which, as Dr. Lustig has said on previous interviews with you, is really the cornerstone. Fat in the liver is the cornerstone of metabolic syndrome. And it's not just that fat in the liver drives metabolic syndrome, it's that metabolic syndrome drives fat in the liver and the associated damage. So that's an important component. And then the other thing is that we're dealing with a disease that is an obesity-related disease, or at least a metabolic syndrome-related disease. And having the word fatty can sometimes be stigmatizing to patients. So that's the reason why in June of 2023, 20 different liver societies and GI societies got together and agreed that we'll change this disease to, it's a mouthful, metabolic dysfunction-associated steatotic liver disease. So MASLD is what we call it. Steatosis means fat in the liver. Obviously, metabolic dysfunction means it's associated with metabolic syndrome. But it's a mouthful, and it's a little awkward, obviously, when you're talking to patients. But it does properly paint the disease as what it is. And so, when we think about MASLD, like I said, it affects 35% of the population. So just a huge, we're talking about over roughly 120 million people in the US right now. And you take a third of them and they have this more dangerous version. So MASLD is fat in the liver, plain and simple, more than 5%. So, you've had other experts on here that talk, Dr. Lustig in particular said that if there's more than a half pound of fat in the liver, then that can be damaging. Well, that correlates to greater than 5% fat. So the average liver weighs around 1,500 grams or so, 1,600 grams, which is roughly like 3.5 pounds. And so if you take more than 5% of that, that's about a half pound. So that's where those numbers come from. And that's when we know that it's pathologic. Up to 5% fat can be normal. And past 5% is considered abnormal. Now, while it will probably lead to metabolic dysfunction, just having fat in the liver doesn't necessarily cause the liver to get sick. And so there's two things that I think that we should definitely jump into, and that is the effect of liver fat on metabolic syndrome and other metabolic disease, as well as what does the fat in the liver actually do, right? So obviously my area of true expertise is what does the fat in the liver do? And when we have just plain fat in the liver, what I tell patients is that it is an independent cardiovascular risk factor. So it really does drive metabolic disease. And we know that to some extent, the more fat you have in the liver, the more risk, the more metabolic disease it can drive. There was a study that was presented at the liver meeting last year that looked at people's ASCVD risk score, the most commonly used cardiovascular risk stratification calculator. And less than 7.5% is considered low risk, and greater than 7.5% is considered higher risk. Well, if you were less than 7.5% by your ASCVD risk, but had fat in the liver, your risk was just as high as the people that were greater than 7.5%. And if you were greater than 7.5 and added liver fat, it pushed that even higher. So it really highlights the fact that independent of everything else, if you have fat in the liver, it really drives cardiovascular disease. And, I'd like to come back to that topic of like, how does it interact with the metabolic syndrome? But shifting to the liver, which is my love, just having fat in the liver doesn't necessarily drive damage in the liver. But there's a subgroup of patients, and we don't know exactly what causes those patients to have this characteristic, but there's a subgroup of patients that the fat isn't just plain fat. The fat becomes inflamed, and that inflammation can lead to scarring. And as you accumulate more and more scarring, that is what the definition of cirrhosis is. And then over time, as things get worse, that cirrhosis can progress to cirrhosis with liver failure. And that's from a liver standpoint, that's the scary part, right? So while fat in the liver by itself is a metabolic problem, fatty inflammation, or so not just MASLD, but what we call steatohepatitis or MASH, that's the dangerous, from a liver standpoint, disease. And so only, 30% of 35%, right? It doesn't sound like a lot, but when we think about the size of the denominator, it's a massive amount of people. We're talking about the number 2 most common cause of liver transplants in the modern era, well surpassed hepatitis C and just lagging a little bit behind alcohol. But it's also the most rapidly growing indication for liver transplants. And it's already the number 1 indication for liver transplants in women, people over 65, and those who develop liver cancer. So that's the other thing that's very important. People with the more advanced or more dangerous fatty liver disease have increased risk of liver cancer, even if they never develop cirrhosis, which is the traditional risk factor for liver cancer. So, a really, really important disease, and a disease that's affecting a lot of the population without them ever knowing about it. There was a study that looked at diabetes clinics, and they just randomly screened diabetes clinics with non-invasive tests that measure liver scarring. And 14% of the patients, 14 in one study, 17 in another, percent of patients had advanced liver disease that they were unaware of, right? So if you walk into an endocrinology clinic and you say, hey, we have 10 people on the schedule today, one of them has cirrhosis and doesn't know it, right? Like that's every single clinic you have, right? That's something that's really frightening. And so it's led to screening algorithms that have been brought around to start to identify these patients, because as of March of this year, there is a new medication that is approved for liver fat, but there's always been a treatment for liver fat, and that's lifestyle change and weight loss. And it's so interesting because a lot of these medications that we're using for weight loss are also being studied for fatty liver disease. And one of the most interesting things that I noticed is that in some of these clinical trials, people are getting really profound weight loss on these medicines, which is what we expect. But the benefit in the liver that we're seeing is good. It's very good. In fact, it's really encouraging. But it's not as good as when lifestyle-based weight loss has been studied for the disease. So one study in Puerto Rico looked at people who were on actually a diet that's probably not great for the liver, a low-fat, high-carbohydrate diet. But it was, calorie reduced, and people lost weight. But the point is that people that lost 10% of their body weight, those who had scarring in their liver, damage in their liver to start with, 80% of them improved that scarring, right? The most recent medicine that's been improved, 26 to 30% of people respond to that medicine, right? So it does speak to, especially for the community that we're talking to today, how important lifestyle changes are, as opposed to just popping a pill or taking an injection and losing weight. It's not to say that those medicines don't have value. In fact, they are going to be the future of MASLD and MASH care in conjunction with lifestyle change, because, you can go on a medicine, but if you're still eating a highly processed, refined carbohydrate, non-fasted diet, you might not have the same success as that if you take that medicine and change your lifestyle and start exercising and do all of the other things. So, fatty liver disease is a major problem. It's an epidemic from a liver standpoint. And, when we look at the numbers for how many expected liver-related deaths, how many liver failure events, it's just astronomical. And there's no way that the healthcare system can really tolerate that. And there's certainly not enough transplants, available organs to do liver transplants for these patients. And so, it's something that we're hopefully finding the patients that earlier. We're instituting lifestyle changes. There's a a rebirth of metabolic disease in the current era, right?
Yep.
Maybe driven by some of these medications that do such wonderful things for weight loss, but also driven by this new interest in different modalities from a lifestyle-based method, whether it's a carbohydrate insulin model, whether it's intermittent fasting, whether it's glycemic index and raw diets and unprocessed diets.
Right.
This real new focus on what are we putting into our body and how are we living our lives. And one thing that Dr. Lustig talked about in the past is about how do we deal with stress? How do we deal with mental health? And how does that impact us? When we don't sleep, a person that hasn't slept or has poor sleep, it's the equivalent of a five, like we should, obviously, this, I'm preaching to the choir here, but it's the same as a 500 calorie increase in their dietary intake, and so I think it's a really exciting time because people are recognizing fatty liver disease or steatotic liver disease or MASH as a cornerstone of metabolic syndrome.
That is just so exactly right on. And thank you for that awesome summary and understanding. I have a question for you. So a lot of people will come in and they've heard these talks, they've heard about fatty liver or MASLD. And the number one question I get is, how do I know if I have it? And I'll often hear things like, well, my doctor checked my enzymes and it said my liver looks just fine. And
Yeah.
so could you speak to that?
Yeah, thank you. What an important question. So your liver enzymes can sometimes correlate with how much damage or inflammation is in your liver, but very often don't. Up to 30% of people that have advanced liver disease from MASH will have normal liver enzymes. And it's because and by the same token, you can have very, very high liver enzymes, and there might be some inflammation in your liver, but there might be no damage, And so the best way for us to assess both, is there fat in the liver, but more importantly, do you have MASLD, just plain fat in the liver, or do you have MASH, fat that causes inflammation and damage? Probably the most effective way that we can do this is a test called elastography. There's a bunch of different modalities. There's an ultrasound-based one. There's something called shear wave elastography. There's radio frequency, something called RF. There's a bunch of different types of modalities that what they're all doing is measuring the stiffness of the liver. The most common one I should just mention is something called a FibroScan. That's the one that's probably most widely available. But there's all different companies that are making new technology that all are trying to measure liver stiffness. And the reason we measure the liver stiffness is because the stiffness of the liver is a correlate for how much scar tissue or damage is present in the liver. All liver diseases lead to inflammation, and inflammation leads to scarring. And as scarring progresses, that's how you get to cirrhosis. So using the stiffness of the liver, we can make an approximate guess for how much damage is present in the liver. Now, that same technology can often measure the amount of fat in the liver. And so if we see fat in the liver, plus a lot of stiffness, plus a lot of scarring, we know you have MASH. We have that more dangerous version of liver fat. If we see just plain fat in the liver without scarring, we know you more likely we know you have MASLD, but you probably don't have the dangerous version, MASH. But the shorter answer to your question is we can see it on ultrasound or liver biopsy. But also like any imaging of the liver. That's the way to definitively say that. But again, when we're talking about 35% of the population, and we're talking about risk factors like high triglycerides, diabetes, excess body weight, especially if you gain weight in your midsection, that's so many people, right? We're not going to be screening everybody. So the current guidelines that have been put out by Endocrinology, Liver Society, and Primary Care is that we need to find the people that are the highest risk, not just for having fat in the liver, but having the dangerous fat in the liver. And so the people that have been identified are people that don't just have obesity, but have medically complicated obesity, right? So not just I have obesity, but I have obesity with elevated triglycerides. I have obesity with high blood pressure, right? And so what the strongest correlate is probably obesity with 2 metabolic risk factors, or people with diabetes. right? From a metabolic standpoint, that is the single most important risk factor is diabetes. But there's other populations that you don't always think about. So those are the people that when you're saying, hey, do I have liver fat? I have normal liver test, but you're diabetic and have high triglycerides and you gain weight in your midsection, you should probably get checked out, right? And there are ways that we'll talk about that you, without having a specialty test like liver stiffness, that you can at least do a rough guesstimate for your risk of of having advanced liver disease. But beyond just the people with metabolic syndrome risk factors, it's also people with a family history. So anyone with a first-degree relative that's had cirrhosis from MASH has a 12-fold increased risk of developing advanced liver disease, or having advanced liver disease. People with metabolic syndrome who drink a normal amount of alcohol have a massive increase in their risk of having advanced liver disease. So it's interesting, the synergy. So alcohol also causes fat in the liver. And the synergy between alcohol-related fat and metabolic-related fat is really remarkable. We're talking about a 3 to 7-fold increase in risk. And
Wow.
I want to be clear what I said there. That's a moderate amount of alcohol. That's not excessive alcohol use, right? So if you fall within the CDC guidelines of, 10 drinks for a woman, 20 drinks for a man, and that's even being conservative in some measures, just having that amount of alcohol plus metabolic syndrome massively increases your risk compared to just having metabolic syndrome alone. And the opposite is also true. If you have alcohol use disorder with or without metabolic syndrome, it makes a huge, huge difference. So, when people have MASH, right, and I see them and they're like, yeah, somehow we find out on a biopsy that they have, pretty aggressive inflammation related to the fat. And they say, well, I don't drink in excess. And I said, yeah, but for you, even a small amount is excess, right? So, so that's an important population. The other population is, I apologize. So we talked about people who with a family history, diabetes, medically complicated obesity, and then those who have moderate alcohol use. Those are the big populations. But I think the biggest thing when we ask the question of, is this, do I have this, is asking the questions, what are my metabolic risk? Do I have diabetes? And if I have metabolic syndrome, how many components of the metabolic syndrome do I have? So there was a really interesting study from the NHANES survey, the National Health and Nutrition Examination Survey, that said that if you have three risk factors for metabolic syndrome, your risk of having advanced liver disease was relatively low, below 10%. But if you had all 5 components of the metabolic syndrome, you have a very high likelihood of having advanced liver disease. Right. And you and I both know that there's lots of people out there with 5 risk factors for metabolic syndrome. And so up to 30% of those patients have advanced liver disease, or as an estimate, which is just really impressive. So don't pay attention to liver tests, pay attention to risk factors.
Love that. Love that. So just curious, what are your thoughts on fruit juice?
Oh, fruit juice. Fruit juice is it's not great. It's not great. Yeah. No, so one of the things patients come to me, they're like, well, I'm not having fruit juice, I'm having a smoothie. I'm like, so why did you take that perfectly good fruit and you were going to chew it up and take the time to chew it, swallow it with all the fiber that was associated with the soluble and insoluble fiber, and you squeezed out the juice and then you just drank the pure sugar water, right?
Totally.
And so but I say that a little bit flippantly because there's so many people. I mean, heck, there used to be a juicing craze out there, right? And so that was considered healthy. What people have to remember is that juice has tons of health benefits. Juice has antioxidants, juice has vitamins, fruits, period. Let's just say not juice, but fruits have tons of benefits, but they also have a ton of sugar. And fructose is a sugar that has been shown to be particularly toxic for the liver. In fact, more toxic than table sugar itself, which is really important because fructose has often been thought of as being a low glycemic index sweetener. It's in agave, but but specifically, and I'm not going to. There's a lot of controversy on, the role of fructose, and if you get Dr. Lustig back on to talk about fructose, you might blow a gasket. But there's a lot of information specifically within the liver in terms of how fructose is processed in the liver, its ability to induce novel fat in the liver, its ability to create lipotoxicity, so fat-related damage in the liver, and its ability to create toxic compounds, as well as its ability to work in the intestines and increase some of the bacterial byproducts that, hey, where do they go from the intestine? The first stop is the liver. So, a lot of the fruit sugars, we have to be a little careful. I have a patient that came to me with stage 2 scarring. Stage 4 is cirrhosis. She was otherwise perfectly healthy, exercised all the time, no truncal adiposity. And we're just going through a history. And she's like, I love fruit. I have 20 pieces of fruit a day. And I was like, she's like, that's mostly what I eat. And I said, well, that's a lot of fruit. That's an incredibly large amount of fruit. And, sure enough, as she got her fruit intake to a more reasonable level, it, rapidly improved. That's another important thing that we have to talk about with fatty liver disease is the ability for your liver to heal, right? So the liver is one of the few organs that does have that ability that once damage is done, really from any cause, if you can take away the things that are hurting the liver completely, the liver can heal. So that's why in that study that I talked about weight loss, right? 80% of people who achieve 10% weight loss had improvement in liver scarring. We used to think that once the scar tissue is there, it's there forever. But we know from hepatitis C and hepatitis B that scarring can get better once we've treated the disease. And now we know that's true for both alcohol-related liver damage and metabolic syndrome-associated liver damage.
So love that. That's one of the fascinating things about the liver is that ability to regenerate and heal. And so I really, really love that. So on that note, what would you recommend for people to protect their liver and or work on healing their liver?
Yeah, so there's only one liver superfood, and I say this with unequivocally,
Okay.
and it's black coffee.
Wow.
Yeah, it's like
Yahoo.
it's one of the things that like you hear about this and you're like, this is total tabloid science. And you go and look at the data, and I'm a basic science in my original training.
Yeah.
And the data is just, it's like unbelievable. Like
So awesome.
it doesn't even make sense how good it is. Like it's like somebody
Yeah.
made it up,
That's so
And so
great.
now in all of the liver meetings, all the liver society, when they're looking at behavioral things and they're looking at interventions, people are recording how many cups of coffee people have. So
Great.
black coffee is what's been studied is
Mhm.
is from a dose dependent nature, reduces the risk of developing cirrhosis in people who have excessive have excessive alcohol use. In people who have cirrhosis, it decreases the rates of developing liver cancer. And
Wow.
it's dose dependent. So if you drink 2 cups, it's here. If you drink 3 cups, your risk is further lower. If you drink 4, so there's
Wow.
actually a dose dependent response. So black coffee, I know there's a lot of other problems with caffeine and all those other things. But black coffee is truly a liver superfood. Now, to be clear, that's different from the Dunkin' Donuts, or the Frappuccino with all the sugar and cream and things like that.
Right, right.
That's the story. But black coffee is
I love it.
great for your liver. But the one thing I will caution people to say is
Mhm.
that everything you ingest goes to your intestines and then gets processed in your liver. Your intestines is just most of the time just a bypass, so like a pass
Yeah.
through. It's in the liver that if that thing is dangerous, that we first find out. The number one reason why prescription drugs get taken off the market is liver toxicity, because again, everything gets
Mhm.
processed, detoxified, broken down by the liver. So when it gets broken down, if something's toxic, what does it hurt? It's the liver. It's part of the reason why the liver can regenerate, because it needs to be able to take a hit from something bad, break it down, detoxify it, get it out of your system, and then heal. And so, you know, herbal and dietary supplements, there's nothing wrong with them as on principle, right? A lot
Mhm.
of these medications help people. And I think that's the first thing that I say to my patients. I say, are you taking this because someone told you it was good for you? Or are you taking this because you feel better on it? Or because you've
Mm,
seen
love that.
empiric evidence that it helps you? And those are two different answers. And so herbal and dietary supplements are this, if we take them all as a single drug, it is the second most common cause of drug-induced liver injury, right? And it's not because there's something wrong with natural medications. I mean, one of the most common medications we use is ursodiol, right? Which is a
Yep.
natural bile acid that we make. In the GI world, we use sulfasalazine, which was derived from a tree bark. And so it's not to say that natural medicines are bad. But like I said, prescription drugs, they go on clinical trials that have 3,000 people in them. They then get studied for another 10,000 people afterwards with post-marketing data. And the incidence of liver failure with those drugs when they get pulled is like 1 in 10,000, right? So it's
Mm,
a rare event, but it can happen. But a lot of herbal and dietary supplements don't necessarily have to go through that rigorous testing. Doesn't mean they don't have value, but it just means we have to be careful. And I think the more important thing is that they don't always get as regulated, right? So,
true.
I have a patient that died of liver toxicity from a glucosamine and chondroitin supplement. And
Oh, wow.
it's not glucosamine and chondroitin, right? Those are perfectly
Yeah.
safe agents, right? But
Yeah.
it was something that was in the packaging material. It was
Wow.
something that was, sometimes you'll see it in an herbal blend that's associated
Mhm.
with the supplement. So you just have to be careful. And it's not to say, I mean, I have a list of thousands of prescription drugs that cause liver toxicity, right? And these herbal and dietary supplements are just no different than that, right? But they haven't been studied. And so the other thing that I'll say, milk thistle is probably one of the most common things that people use for their liver. And it's an herbal and dietary supplement, and the active ingredient is called silymarin. Well, the National Institutes of Health asked for research into silymarin a while ago, probably a decade plus ago. And they had asked because there was so much data out there saying that it improves liver tests. And what they found
Mhm.
was that in a petri dish, it can improve liver function. It can improve liver enzymes. And in animal models, and even in some human studies, it improves liver enzymes. But it's never been shown to change the course of any liver disease, right? So when it's studied in NAFLD, it's never been shown to improve scarring so again, and we already talked about that liver test abnormalities is not the best indicator. But I have patients that say, well, I went on this, my liver test got normal. I said, but did your scarring get better? Right. And so, you know, there's still a lot to learn. I think there's probably some benefit to silymarin. I just don't know what it is and in what dose
Mhm.
and in what formulation and how often it needs to be taken. And I don't think anyone knows the answers to that. So, it's with a bit of caution. So liver superfood coffee, but then the diet that's been studied probably the most for liver disease is the Mediterranean diet.
Mhm.
And because we know the profound effect of weight loss on altering liver disease, I recommend a modified Mediterranean diet, basically a low carb, high protein Mediterranean diet. And the rationale behind that is the appetite suppressive effects of protein, and the fact that, again, following what I believe is a valuable lesson when it comes to weight loss, not necessarily the science of obesity, but functional weight loss in patients, I think is more easier to achieve with a low carbohydrate diet. And so, and there's science behind it, but just because it's one of those things. It's funny. I remember talking with you when I first was on the obesity medicine journey, and
Yeah.
it was about, it's not always what you can prove without a shred of doubt, right? That's in a special feeding study at Harvard University has been shown that
Yep.
this makes this difference. It's what works for your patients, And I've tried, I've been an obesity medicine provider now for we're coming on 7-10 years. Um, and I it's what works, right? It's what works for people. And I think that fasting is another thing where, there can be a New England Journal article out there, or I think it was JAMA, right? That says,
Mm-hmm.
oh, well, time-based eating versus, calorie reduction, it doesn't make a big difference, but like, it's what works, right? It's in the
Yep.
personal experience.
Yeah.
So, Mediterranean diet, a low carb Mediterranean diet is probably the one that's been studied the most in terms of benefiting the liver and exercise, right? I mean, I think it's the whole thing, right?
Yeah.
There's no one thing. Getting enough sleep, not eating processed foods, all the things that we know are good for us, but are just so damn hard to achieve in the modern era, right?
Oh, totally. You are so right on. You know, uh, so one of the things that I love about when you see patient, when we have mutual patients and you're seeing my patients is they come back and they're like, he makes the recommendations so actionable and doable. And I think that's the key. Exactly what you're saying is what actually works for the person and having lots of different ways to think about it and understanding what the end goal is, which is really that metabolic health and improving that liver. So I just love, love, love that. And speaking of taking care of your liver and all of that, what do you do? Like, what's your, where do you put your energy? Understanding everything you do about the liver, how do you take care of yours?
Yeah, I mean, I made a decision a little while ago to stop drinking.
Hmm.
So it's incredible the parallels that you see between, you know, alcohol use and sugar use and other things that all work in the same central addiction pathways. Um, you know, when I stopped drinking alcohol, I was like, crap, I'm craving sugar like I never have before, and when
Yeah.
people go on Ozempic, they suddenly stop drinking and gambling, and we're
Yeah.
actually doing a
Yeah.
clinical trial at looking at Ozempic and a couple other agents in alcohol related liver disease,
It's
not just
awesome.
metabolic.
Yeah.
And so,
Yeah.
but that's one thing, right? So it's interesting. We talk about, hey, what's a safe amount of alcohol? 7 to 10 drinks for a woman, 14 plus to 20 for a man. Those are rough numbers, but the CDC is going to change those recommendations, right?
Yeah.
I was talking with Gail Bash, the director of addiction psychiatry at Rush, and
Hmm.
they're going to change those recommendations because really there's no safe amount of alcohol, right?
Exactly.
There's low risk amount of alcohol, just like there's no safe amount of cigarettes to smoke, right? So
Yep.
if you smoke one cigarette a day, are you going to get lung cancer? Maybe not, or once a week. You're probably not going to get lung cancer, but is it healthy? Is it safe? No, probably not.
Yeah.
And, there's so much unknown. What genetic predisposition do you have? Do you have addiction genetic predispositions? Do you have metabolic syndrome? Right. And, that's something that I've probably struggled with weight gain, weight loss myself, as I've gone through this journey. That, do you have metabolic risks that make a normal amount of alcohol higher risk than it would be for a person without metabolic syndrome? So that's one thing. And I definitely try and focus on, a low carbohydrate, low glycemic index diet. Trying cutting out the simple sugars. And one of the things that I am trying to be even better about now, or really being better about, is trying to cut out some of the processed foods. It's
Yes.
hard, working as a
Yeah. Oh,
physician,
yeah.
just running, from place to place. And
Right.
sometimes I'll send a patient to you and they'll come back to me and say, well, Fran and Dr. Parrella do not want me eating this. I'm like, oh crap, I better go look that up. So, but there's the real food process, right? That,
Yeah.
um, sometimes it's a convenience thing, but again, it always goes back to what works for this patient, right? Yes,
Exactly.
it's better for them to eat a chicken breast than a protein shake, but if they're not going to have a protein shake, or if they're not going to cook chicken breasts and eat them, then maybe it's a reasonable. And we have to. It's the same thing with like diet sodas, right? Like, are diet sodas
Yep.
good for you? Absolutely not. Are they maybe a little bit better than a full Coca-Cola? Like maybe, or like, they have the risks and benefits. So,
Yeah.
and,
Risks and
and so,
benefits. Yeah.
it's one of those things where working with the things that I do are, definitely focusing on trying to maintain a low carb diet, focusing on, obviously other toxins to the liver, right? Alcohol
Sure.
being the primary one. Um, exercise, right? Exercise has been shown to be beneficial for fatty liver disease and for even alcohol-related liver disease, and not just aerobic exercise, but strength training. That's been a big focus of mine recently. Um, Getting sleep, right? So all of the things that we know are good for us can also help the liver. Like, it lives at the crossroads of our body, right? It's right there in the middle of our body, right underneath our heart. And so all the things that we do that we just know are good for us, getting sleep, managing stress, not eating simple refined sugars all the time, eating more protein, exercising, they all help the liver. But I think that the top three for me are avoiding alcohol, eating a low carb, high protein, kind of Mediterranean real diet, as opposed to, and minimizing processed foods. It's probably the top three from a behavioral standpoint, and then adding on all the other things that you should do just to be a healthy person.
Oh my gosh, I love it. It's so great. And I really appreciate those like very simple, things to focus on, because I think that makes it easier to, pick one and start working towards that. So I really love that. Is there anything that you would say, last question really, what absolutely don't you want to do? Or what's one thing that really just pay attention? And if you could cross off one thing, that this would be the thing, just don't do this and this will be better for your liver.
Yeah, I mean, so if I take it out of the alcohol realm, that's probably
Hmm.
the one thing that's the
Yeah.
easiest. Certainly not drinking to excess. And if you have metabolic risk, really minimal drinking altogether, because of what we were talking about the synergistic effects. But if you just take it to what we are here to really talk about, which is metabolic related liver fat, it's
Hmm.
probably in carbohydrates. It probably exists
Okay.
in excessive simple carbohydrate intake is probably the number one driver of liver fat. So the simple sugars would be something that I think is um, hard to give up for a lot of people because it's so addictive.
Yeah.
But I think that is probably the single most important thing you can do for MASLD, right? So, I think Dr. Lustig in one of his YouTube videos said it's from alcohol and sugar, right? And so that he's right? Those are probably the two most dangerous things that you could do to your liver is
Yeah.
alcohol and sugar, especially at the same time.
Oh my
So as much
gosh,
as we all
totally.
love as much as we all love a sweet strawberry daiquiri,
Maybe
probably not
not
the
so
best
good.
idea. Yeah.
Choose that coffee instead. All right. Well, that is super helpful. Dr. Janardhan, how can people get in contact with you? I know you're a hot commodity. So how could people get in contact with you?
Yeah, absolutely. I'm the medical director of liver transplant at Rush. So just I think I'm available through their website in a way to contact me. I don't have a public facing. I think I have a Twitter profile that I never use. I get yelled at a lot by my staff about, hey, you need to get out there. But I do have a Twitter handle. I think it's called Fat Liver Doc.
Oh,
So
great. Okay.
that would be one at Fat Liver Doc. That,
Uh-huh.
hey, maybe it'll prompt me to start using it more. And otherwise, yeah, just through Rush Hepatology.
Yeah, absolutely. And I think, Sujit, what you've done for our community is make this really accessible and approachable, because fatty liver sounds extremely scary. And a lot of people have misunderstandings about it. And I think one of the things Dr. Lustig said, which has always been really helpful, is he cites his study where he showed in children he could reverse fatty liver within 9 days by cutting out the sugar, even if it was, starchy
Yep,
carbs that were still put in its place.
yep,
And even without weight loss, that was possible. And so, understanding that for everybody out there, if they're concerned, there's ways to test, and there's specialists like yourself that can help, and that liver enzymes aren't the answer. There's much better ways to assess that and how to think about it. And then what can be done. I mean, seriously, I'm so happy to hear about this coffee. I did not know that. So that's like a total win. And,
yeah.
helping people understand what they can do. And I loved also that you pointed out early on that lifestyle matters, really to do that in conjunction with anything else, because it is the foundation and it's way more powerful than people give it credit for. So I think
Right.
that's really reassuring.
And it's one of those things where you just don't want to be sitting on a ticking time bomb, right? So like, as
Totally.
much as we want to do all the lifestyle, because someone could walk away from this and say, great, I'm going to drink coffee, I'm going to cut out sugar, I'm going to do all of these things. But if you already have advanced liver disease, you have to have someone that knows what they're doing to take care of that.
Yeah.
And so, because so many of my patients show up when they need a liver transplant, and they
Yeah.
didn't
Too
know
late.
up until that point. And there are, as we've
Mhm.
alluded to, there are things we can do, lifestyle, medications, etc., that can halt this disease, if not regress this disease. But if we're not aware of it, we can't affect that change.
Yeah. No, absolutely. No, I'm so grateful for your time, Sujit. This is so fantastic. I know you're on like a talking spree for, the new medication to treat fatty
Yeah,
liver. And I'm super thrilled that there's now more treatments becoming available. And so thank you so much for your time.
absolutely. Yes, there are new treatments that are going to be available that are probably even more exciting than the ones that are currently available. But I will say to you what I said to you when I first met you. There's always been a treatment for fatty liver disease, right? And that's weight loss and lifestyle change, and that's the cornerstone of that treatment. So medications, great, but
Yeah.
always just in conjunction.
Well, I don't know how many hepatologists also are boarded in obesity medicine. I don't know that we can put any more letters next to your name, but you have definitely become the expert of all experts.
No,
No, go
the
ahead.
only thing that we didn't really talk about, which,
Mhm.
if you want to add this in at any point,
Yeah,
was, Dr. Lustig had talked about how hepatic steatosis is the kind of the foundation of
ground
metabolic
zero.
syndrome. And I think that I'm sure that he's gone into more detail than I will go into, but one of the things we know about liver fat is, he talked about this interaction between subcutaneous adipose tissue, visceral adipose tissue, and liver fat. They've done
Yep.
studies where they did MRI analysis of people with excess body weight, and one thing that was always commonly thought was that there's a huge difference between the races. So Hispanics were far more likely to have liver fat, and then followed by Caucasians, followed by African Americans.
Mm,
And initially it was attributed to a particular genotype. There's a gene polymorphism called PNPLA3 that has actually been associated with multiple different liver diseases, but in particular, it's the bad version of that gene is present more in Hispanics than African and then Caucasians and then African Americans. So for the same
mm,
overall body weight, African Americans are far less likely to have liver fat and far less likely to have the more dangerous version of liver fat. But one of the
mm,
things they also noticed was that people have different body shapes. Hispanic
yep.
patients are far more likely to have central adiposity, the apple shape versus the pear shape. And so the interesting thing is they did an MRI based study where they looked at the amount of fat and subcutaneous fat, visceral fat, and liver fat. And what they found was that if you control for the amount of visceral fat, then there's no difference between the races. So it
Oh,
was really about
interesting.
belly fat. It was really about visceral fat that was driving the liver fat. And that pans out in experimental studies when they've shown that the number one source of liver fat is visceral fat. So it gets mobilized from the insulin resistant visceral fat and goes into the liver, right? And so that gets to, hey, how this metabolic syndrome can affect the liver. But one of the earliest steps of metabolic syndrome is liver fat, because once you get liver fat, you get liver insulin resistance. And that can in turn drive peripheral insulin resistance, which defines diabetes and prediabetes. So it's really one of the earliest switches that happens in terms of initiating the metabolic syndrome. And so again, it's a circular relationship, which is, I think, that one of the reasons why we're seeing such amazing treatments for fatty liver starting to take shape is because they got out of the liver, right? They started
Mm,
focusing on the metabolic syndrome that which is also one of the motivations for changing the disease. So at the same time they changed the disease, they started focusing on metabolic therapies for this disease, and I think that we're finally starting to see some real progress.
that's really impressive. Yeah, no, I think this part is so important, and I'm so glad you shared that. Um, yeah, absolutely. Well, that's so what do you suggest with regards to how you would talk to somebody about knowing if they're, before that switch is going off, right? So before you're going to see liver fat, like what would you look for? Or what can somebody, they might say, oh, I'm really tired, or my immune system's shot. Like, is there something that would give a clue that you might be heading in that direction? A lot of people might talk about like menopause or, the
Yeah.
waistline increasing, but that might be already too late.
Right. I think you're right. I do think that it's probably hard to catch before you have liver fat because you're never going to feel
Yeah.
that, right?
Mhm. Yeah.
Um, but you know, I think it's the lifestyle. I think
Mhm.
it's the mindfulness, right?
Mhm.
I think it's the, you know, we Dr. Lustig talks a lot about stress, right?
Yep.
About
Yep.
stress-based lifestyles.
And
And
amygdala. Yep.
so,
Mhm.
are you not sleeping, eating fast food, eating processed foods, even if you're 20 and athletic and look great, but you're burning the candle at both ends, People are
Yeah.
like, "Oh, as you get older, it's harder to lose weight." And it's your metabolism slows. The actual reduction in your metabolic rate is actually pretty small per year.
Yeah.
What it is, though, is your ability to tolerate the lifestyle that you built in your 20s, right?
Mhm.
So the
Mhm.
ability to not sleep at all, right?
Yeah. Yeah.
I mean, gosh, we went through medical training, right? So we did all of the things. We ate
Right.
terribly, we
All the
didn't
terrible
sleep,
things.
we were stressed out, and so I think that, like, that is really the earliest sign that, hey, I'm run down. My mental
Yeah.
health isn't great. I'm suffering from anxiety. You know, really focusing on that wellness and that mindfulness, I think, is a really important part of having the lifestyle that doesn't result in the first step, right? Which is
Yeah.
the liver fat. And, potentially allows for more of the metabolic flexibility that you've spoken to. Right? That where if you don't have that hypercortisol driven, carbohydrate sensitive physiology, then maybe, you know, you can, by not having that levels of stress and focusing on mindfulness, maybe you do have a little bit more flexibility. And so, I mean, I don't know the data behind that, but it makes sense in my head, And so, I think that if I was to say, there's nothing you can really do other than the stuff we talked about. Don't drink a bunch of alcohol. Try and avoid simple sugars. But in terms of knowing you're there, is look at the rest of your life and see, not just are you happy, but are you well?
Yeah. I always tell patients, think about, are you feeling better day after day? Are you feeling worse day after day?
Yep.
If you're starting to feel worse, something's not right. And
Right.
usually, like you said, the liver is the first pass. So,
Yeah.
that is really like a good place to start thinking about. And I think it's such a cool organ. So, thank you so much for sharing your expertise with us.
Absolutely. Happy to do so. Thank you so much.
Awesome.